Eastern Daylight Time. So let me greet you to the afternoon, and I'm happy to see all the people here, including folks in the HAPI program and other students at Georgetown, as well as outside guests. If you're not familiar with the Health and the Public Interest Program, it's a one-year master's program. Elizabeth is going to put the URL in the chat. You're welcome to go to our website, and there are recordings of previous seminars that are great to look at. This seminar will also appear there within a few days. And if you're interested in considering our program for your education, applications are closed for the coming year, but the instructions and descriptions of the program are there. It's a one-year program that emphasizes the non-clinical determinants of health and healthcare. Specifically, we look at social determinants, effects of marketing, effects of legal and economic issues, et cetera. So we look at the broad view of what affects people's health. The way this is going to run this morning, our moderator is going to take over from me in a second and introduce the speaker. But after a short introduction by Andrew Ridzik, we're going to have a talk by a special guest today, Murray Ross, who is just now retired from Kaiser Permanente in California and is a well-known person in the public health world. I'm sure you'll all enjoy his talk. After his talk, we'll take questions first from students of the seminar and then from outside guests. And I want to say something to the students real briefly, which is that, you know, I'm compiling your discussion board entries and attendance data. And if you want to put in discussion answers even late, you're going to be better off than not doing it at all. So please fill in those empty spots on your assignments. So with that said, Andrew.
Yeah, so I'm Andy, or I go by Andrew as well. I'll be introducing Dr. Ross for the seminar. So Dr. Ross was the vice president of Kaiser Permanente in Oakland, California, where he led the Kaiser Permanente Institute for Health Policy. Also served as the senior lecturer at the Kaiser Permanente Bernard J. Tyson School of Medicine, and he chairs the boards of the Institute for Clinical and Economic Review and the Network for Excellence in Health Innovation, and served on the board of the Canadian Foundation for Healthcare Improvement. Today, Dr. Ross is going to be talking to us about health policy and what the pandemic taught us. So please welcome Dr. Ross.
Well, thank you very much for having me. And I just want to say, Jay Crossan, I could see two faces and you're one of them. So good morning, fellow faculty at the KP School of Medicine. So as we were negotiating a title for this seminar, I went back and forth on the verbs of what did the pandemic teach us? What did we learn? What are we going to apply? Because teaching is just the first step in all of this. And we'll go through some of that today. I'll just warn you in advance that I'm going to have some crossover here between both care delivery and public health and public policy. And that just largely reflects having spent 2 decades at Kaiser Permanente working in health policy and population health and studying at the seat of the providers of care. And the other thing I'll just say up front is I will, in a couple places, be referencing misinformation and declines in trust of science and evidence. That's a particular joy of mine, but it would be an entire seminar on its own. But if we want to go to that in questions, we can do this. So I want to begin, sorry, my mouse is a little bit twitchy, there we are. Just sort of hitting the treetops of a few things that I think the pandemic revealed to us. First of all, public health being both undervalued and misunderstood. You know, it's interesting when you look at how we focus on health policy in this country, and what gets attention is where there's a stream of money flowing from the federal government to somewhere else. And of course, that's through things like Medicare and Medicaid and National Institutes of Health. And we spend much less time, and those of you who work in public health know this, around, in investing in the future, trying to coordinate between public health and care delivery. And then at some point, making sure that what we're trying to do is actually being understood out there by the people who need to understand it. It's almost trite to say that we need to make racial equity a priority. The pandemic really exposed the consequences of structural racism in this country, and that's hard for people to talk about. I was having a conversation just yesterday with a colleague, and if you can't talk about something, you can't address it. So we have to be honest there, and I'll go into some examples here a little bit farther on. But there's a whole lot of issues around access to care that we know about, healthcare disparities and differential access, but also just confidence in the care system. We learned that care delivery can be improved very quickly. I've heard more than one person say something to the effect of, we made more progress in 10 weeks than we had in the previous decade. Necessity is the mother of invention. I'll talk very little bit about the experience at Kaiser Permanente, where for us, it wasn't so much reinventing what we were doing, it was scaling it up very quickly. We learned that scientific progress can be accelerated. Early on in the pandemic, when we talked about vaccines, there were various numbers floating around the internet of what was the fastest vaccine ever developed. And you'd hear numbers like 7 years or 12 years. And in fact, I was very skeptical of this at first, but de-risking, taking the financial risks out of vaccine development saved a lot of time. Taking technologies off the shelf, the messenger RNA platforms, really helped. We had a science base that was there to be taken advantage of. And then we learned that getting the facts out really fast is a good thing, but there's also risks that things can be misinterpreted, sometimes accidentally, sometimes deliberately. And then I'm not going to talk a whole lot more about this, but as an economist, I watched all the disruption with the supply chains with a little bit of dismay. And we've made movements in our economy, not just in healthcare, but across the board over the past few decades to lean manufacturing and just-in-time manufacturing. And it's all about inventory minimization. And inventory is disruption insurance. You would drive your car around running your gas tank down to empty every time you wanted to fill it to minimize the amount of gas you were carrying around at no benefit. But that's where we've been, and that was costly. And when you get too much reliance on either a limited number of suppliers or a limited number of countries, many of them not particularly friendly to us, that's a problem too. So we need more diversity there. So let me go back and go a little bit deeper on the public health question. And I note here that it's sort of amazing that the impact wasn't worse. A lot of these, the so-called stockpiles proved to be bare. That is a fault of multiple administrations over many years. There was a whole lot of lack of clarity around roles and accountability between the federal governments, the state governments, the local governments, and the private sector. Who's in charge of what? And if you were glued to your television or glued to your computer, an awful lot of finger pointing going on, especially early on. Less surprising is messy data systems and flow of information. I mean, we've been struggling with this as a country now for decades, just on the sort of the care delivery side, trying to get interoperability between electronic medical records. And we're still having that conversation at least 20 years in. But the crossover between the world of public health and care delivery, that's an even sort of more dense membrane. And then the politicization of this and the threats to county officials. Dr. Chris Farnatano was the county medical officer in Contra Costa County, where I live, and he and his family are good friends. And we heard a lot of what was coming to them very personally, and it was just absolutely amazing. Here was a man who was working at significant salary deficit to do public health in in the county, and he's having death threats delivered to his door. But hopefully we have some time before the next pandemic, if this avian flu and whatever else is floating around doesn't turn into it. We can restock supplies, and this time we can mean it. We can start to move to clarify roles and build accountability. Now, this takes leadership somewhere, and I think the leadership has to come from the federal government, since that's where a large chunk of the money is going to originate. But it needs to take place. And then we need to work around to build better connections between public health and care delivery. And, I don't know if it's helpful to look at other industries there or not. I think a lot about the airline industry, and, there's agencies dealing with safety, there's agencies dealing with air traffic control, there's local governments dealing with airports and airlines and slotting, there's pilot training. It's a complicated industry, and they seem to manage to do it. So digging into health equity, again, it's not news that there are disparities in health coverage and access to care and income and employment and support systems and chronic disease burden. But I think where the pandemic, it really ripped the Band-Aid off, and it's just hard to unsee how these things came together to magnify the impact. And you look at the mortality rates, the morbidity rates in Black and Latino communities and immigrant communities. And it's not just on the health side, it's that these were the people who weren't working from home. These are the people who were providing services in the hospitals. They're the bus drivers and public transit. They didn't have the luxury that I had to sit in my home office with a nice view out the window, far from any risk. And I mentioned just on the opening there, again, there's also a lack of trust in public health and the medical care system. And if you're so inclined, I recommend reading any of Harriet Washington's books on the topic, medical apartheid being one of them. Again, there's a long, uncomfortable trail of events over a period of decades, and those have been socialized into how people think about care systems. Concretely, we need to think about how certain aspects of our healthcare system actually just replicate the disparities. We've been talking about care disparities for as long as I've been in working in healthcare policy, and it seems that so much of our energy is devoted to documenting more instances of them, as opposed to saying, how is it that how are we going to address it? We need to be able to measure health and racial equity to know if we're improving. And Polly Pittman at the Fitzhugh Mullen Center for Healthcare Workforce Equity at George Washington University has done some interesting preliminary work. We helped co-sponsor that, just to start trying to build some metrics of, if you want to improve equity, you need to be able to measure it. And her team has looked at a number of different domains and areas where we might focus. And then we need to not be just sort of stapling health equity into our policy decisions, but baking it in. And this will be hard to read for some of you if you're on a smaller screen, but this is a rubric that, as you can see from my source note, I pulled off Twitter, but could never find the original. But what it does is it asks, as we're making policy decisions, going from left to right, we have harmful policy that actually worsens racial inequities. Under the 0, under 1, we have broad-based policy that appears to be race neutral, but negatively affects some people. Then we have broad-based policy that maintains current racial equities, doesn't make things worse. Broad-based plans that help to make some improvements, but still tend to, if not properly implemented and evaluate, just replicate the status quo. Under 4, it's at least half of the policy targets of communities of color in a racially equitable way. And then 5 is entire policy prioritizes racial equity. And I would encourage you, this is a rubric, it is not the rubric, so I don't have any vested interest in this, and others could define it a little bit differently. But I would encourage you to think about what are examples that might fit into these different categories. And easy to say that, we're just going to, like the expression health in all policies, we could have equity in all policies, and you know, how should we be thinking about it, and how do we automate that a little bit? The example I will give coming out of the pandemic was, as people were losing their jobs and access to healthcare, there were different actions that could be taken. You could, as we did, automatically, well, not automatically, but you could incentivize states to open up eligibility to their Medicaid programs. You could expand subsidies through the Obamacare, the ACA exchanges. You could subsidize COBRA coverage for people who lose their jobs and want to maintain their employer-sponsored health insurance. And those have different implications for who gets helped in all of that. And I'm not saying one is necessarily better than another, but basically they were done on the basis of dollars spent, and not necessarily on with that thinking to the equity implications. So just a couple thoughts on how technology might improve things, and this is sort of where I cross over a little bit from care delivery, but I think there's still some overlap with public health, because what we really saw in terms of technology coming out of the pandemic was the increase in use of telehealth with virtual visits and remote monitoring, instructional videos, and actually I think Google has been pretty active in that area. Again, being able to make specialist referrals and consultations. We're still lacking in data systems and information exchange. You know, paper just needs to go. When I got my first shot, in my first vaccine in Contra Costa County, they hand printed my name on a little, whatever it is, 4x3 card, and they wrote in the date and stamped the batch number on it. And for all I know, that information never went anywhere, or whether it went somewhere correctly, I don't know, but that was the little piece of paper that I had to hang on to show that I had been vaccinated. So we need to continue moving to comprehensive electronic medical records, not just claims data. I use the term data hoarding when I think about some of the challenges with interoperability. It's not just that systems don't talk to each other because they are different systems. It's that a lot of care delivery systems and hospital systems are not interested in sharing information with competitors, and we need to make that both, I think, more required and easier to do. We saw in drug development how quickly we were able to move forward. We can run virtual clinical trials, genomic sequencing, a lot of things there that technology is giving us that we didn't have this 10 years ago. And there's still missteps that we can talk about, but it will help. And then, there were efforts to do some of this in the pandemic to try and sort of hotspot things. We're used to doing it, or maybe not used to doing it, but we're learning how to make use of artificial intelligence, predictive analytics, and machine learning to look at high-risk patients, before they have an event rather than after. And I think of things like using wastewater screening for the virus to be able to detect when we're likely to see a surge in infections. There were other steps that I'm less familiar with, but technology itself isn't really the problem. We've got lots of fancy technology out there. It's the payment incentives to use or to not use technology. It's the incentives or lack thereof to share data, to make common definitions. And I'll just put up one slide from Kaiser Permanente, and this is from 2012 at the bottom, going up through 2020. We have been, and what the bars are showing is outpatient touches. So the navy blue, those colors are correct, are off, in-person office visits. These slightly lighter blue is telephone, grayish is secure email. And we went from about half of total touches being office visits in 2012, down to about 40% in 2019, pre-pandemic. And then you can see the shift, cutting that almost in half in 2020. And I suspect that actually for 2020, those office visits probably include office visits prior to the shutdowns. So the number during the pandemic itself, I suspect, is even lower. But for Kaiser Permanente, and for those of you who are not familiar with us, we are an integrated care system of hospitals, physicians, and health plan, and have been building out our electronic medical record and our virtual visit capabilities for well over a decade now. And so for us, coming into the pandemic, it wasn't so much as doing something new, it was scaling up something we were already doing. And, that's just sort of, I put here, learning how to break old habits. We have been breaking those habits for a while now, but there are things that you just had to make a decision and say, we're going to go forward and figure out what do we want to keep, what do we want to refine, and what do we just stop doing for now. And maybe, as we come out of the pandemic, we're having to ask the question, so do we go back to the status quo ante of 2019, or do we take the learnings that we've had here that patients, and I don't want to generalize across a generation, but younger patients, millennials and Gen Z in particular, they're used to doing a lot of stuff by phone and on their screens, and don't really relish the thought of a physical office visit. And I think, and Jay Crossan can chime on this later, but I think our physicians and our providers have also developed a comfort level that perhaps they didn't have, several years ago, or certainly not 10 years ago. And it's just part of how we do things now. So where does policy fit into all of this? And how does it make things better or worse? Well, first of all, incentives matter. What you pay for is what you get. And in healthcare, in most settings, we pay for services rendered, and that tends to give us more of those services. In an organization like Kaiser Permanente, where we are closer to having a global budget, we have essentially fixed dollars for a given year through our public programs and employer customers and ACA exchanges and individuals. We have a budget, and you have to make allocations about how you're going to deliver care, and it rewards prevention and appropriate utilization. We have had conversations about value-based payment and value-based purchasing, and we've been talking about these things for decades and not getting a whole lot of traction from my point of view. The conversations are all in the care delivery space, but they apply to population health, that it makes sense if you're in a position to keep people out of the hospital, if you're in a position to test them, to treat them, to vaccinate them. You will do that if you're, as an organization, if you're appropriately incentivized. You just get better alignment there. What can I say? Protecting special interest hurts patients. We have long stories of mergers and acquisitions that are billed as efficiency gains, that when we bring two hospitals together, when a hospital buys up a physician practice, that we'll get rid of duplicative overhead. That never materializes. What we get over and over is increased pricing power that gets used. Great Twitter thread today from United Health Group has now started making advanced loans to some of the provider practices it has been buying up over the years, and is in some cases at least, and don't believe everything you read on Twitter, but there were some citations there, essentially foreclosing on physician practices that fall behind for whatever reason on payments. And it just feels like that's a tough business model. We talk a lot about drug prices in this country. The root problem is that we extend patents well beyond original intent for changes in drug products that are not particularly useful or novel. Licensure, this is, again, all done at state laws, a lot of protectionism across states in who can see what patients. It shows up in telehealth. It shows up in the pandemic when you have a surplus of available caregivers in one state who can't practice in another, and a lot of therapy mandates, again, predicated on preserving incomes of special interests. In health policy, we often focus on the wrong problem. In mental health, for example, mental health parity has been a topic of discussion for 20 plus years. And we can like or not like mental health parity, but the real issue is not insurance coverage. It's actually, do we have the care capacity to take care of people with mental health issues? We focus on patient costs versus system costs. Patient costs matter, but just simply shifting, capping prices on insulin for the patient without doing something about the high price at the front end isn't going to solve things. And then increasingly, and I'm sorry, I'm speaking here from my amount of work I've been doing in drug pricing over the past couple of years, where a lot of energy has been in some academic centers been going to, how do we figure out how to pay for high priced drugs over time instead of addressing high prices themselves? And this shows up in a lot of different places, whether it's people now taking out 8-year loans to buy their cars, people taking out student loans that they end up repaying or not repaying, 30 years after they graduate. And if the problem is high tuition, we should be addressing the problem of high tuition, not just making loans more widely available to get people into trouble. And then good policy is not always good politics. And my favorite example, and you can see this, Kaiser Family Foundation has done endless numbers of surveys on this. Obamacare, the Affordable Care Act, never in any month had a public approval rating above 50% until 2017, when it was under considerable stress with the repeal and replace that was under discussion in the Congress. But its major components consistently exceeded 50% approval, and that was a branding issue. And again, we'll talk a little bit more about this in the public health sense, but all the politicization we had around masking, that we had around vaccines, it was much easier to message Big Brotherism than we were able to message, prudent public health interventions to slow the spread. Losers are louder than winners. When we're enacting policies that change things for people, the ones who experience the change, they know it, and they talk to their representatives in the Congress. And then, we saw a lot of this in the pandemic with constant pivots in policy and messaging, undermining adherence. And, the issue of masks, and in the beginning, we were supposed to be, don't wear a mask because we're trying to conserve them for frontline workers, and then pivoting to, yes, you need to wear a mask in all indoor settings, and et cetera, et cetera. I saw a quote today from Zach Cooper at Yale University, who said, "There's not a constituency for making the future better." And this is just it's a generalized problem in democracies. I'd argue it's even more pronounced in the United States for various reasons. But our political system, which is in charge of our policy system, is really good at responding to short-run things and making people happy today, not worrying about tomorrow. And that's how you end up with empty stockpiles and all the other things that we saw early on in the pandemic. So I want to go through 3 stories coming out of the pandemic. One of them is a little bit of a tangent, but I'll try and bring it back. First one is a success story, and that's vaccine development. You look back on it in amazement that we went 1 year from sequencing the virus in late 2019 in January of 2020 to the first emergency use authorization, EUA, for a vaccine in, I want to say, September of 2020. No, I guess it did come after the election. I should remember this. So December 2020. But that's amazingly fast. The policy, I think, generally got it right. Go big on de-risking drug development. Diversify the portfolio across multiple vaccine candidates. And the outcome is in the States, we got 2 drugs from Moderna and Pfizer BioNTech approved for use, vastly better than anticipating. In the run up to approval, the conversation was about would FDA approve these and what would be the threshold, and numbers that were floating around were around, well, if they were 50% effective at preventing hospitalization and death, that would be satisfactory. In fact, they were in the mid-90s early on before the variants, and that's just amazing. And then this wasn't constrained to the U.S., although the policies played out differently in Europe. But AstraZeneca and Novavax also came on. A more modified success story was the vaccine rollout. The original plan was that the feds would purchase vaccines, make allocations to states in the number of actual shipments, and then states would be left to prioritize which populations got the earliest access to the vaccines. And the reality challenged all of this a little bit. The early production targets weren't met. It was complicated because the mRNA vaccines needed super cold storage all the way along. The National Academy of Medicine and others developed very elegant prioritization frameworks that actually kind of collapsed in the real world. I tracked those pretty closely. I had no objection to the thinking they were providing, but at some point it would have been helpful to have people who've done it in the real world before. The examples I'd give are when we had hard age cutoffs for who would be eligible for to get the vaccine. So if you're 65 and older, you're prioritized. If you're under 65, you're not prioritized. So that means if you have a married couple, one of whom is 67 and the other of whom is 63, you're making 2 trips to the clinic and clogging the lines instead of 1 trip. I don't know where you draw the boundary there, but we need to think about that when we're dealing with family units as opposed to just individuals. And then variable family structures. It's just a lot more complicated than what we still call the traditional family unit. It hasn't been traditional for a while, and we need to think about protecting people living in the same house, not just the people who meet the categories. And then states had to pivot from prioritizing a scarce supply of vaccines to mass vaccination. And that pivot was about 8 weeks, I think, if I'm recalling correctly. That's a complete change in mindset from, no, you can't have a vaccine, wait your turn, to please come today to get yours. And the faster you can get here, the better. And so the result, again, relative to perfection, it was not that. Relative to what it could have been, we made amazing progress in early 2021 with basically surging through the supply of vaccines as fast as we can get them, and it leveled off. And the game shifted from mass vaccination to targeted outreach. And then, as we know, vaccines became a political symbol, and that really sort of started to complicate things. And then I have a non-success story here, which is related only to the pandemic because of the timing of it, but also because it's an illustration of the lack of trust in science, and that's the aducanumab, the drug that was brought out in 2021 for treatment of Alzheimer's. And it was based on a the theory of the case of these amyloid plaques that cause memory loss and cognitive decline that have not been shown to be the case for research across 2 decades. The manufacturer, Biogen, actually stopped its own trial, and then for circumstances that are not yet fully known, revisited the trial data and then focused arm that showed modest benefit. And you don't have to be a trialist to know that that's kind of bogus science when you just take out the half of the trial that didn't show the result you wanted. The FDA ignored its advisory committee, and that's fair enough. Advisory committees are just that. They're not binding, but they went 10 no's and an abstention, and FDA still managed to ignore that and expanded the label for the drug, the conditions for which it could be prescribed, well beyond the trial population. And then, since the evidence wasn't very strong, FDA negotiated a post-market study to be completed after approval, and gave the manufacturer 9 years to get it done. Most of those don't get done in any case, and there's little enforcement of it. But 9 years is, to my mind, a little bit out there. And the implications of that are we got a drug that, with known harms and unknown benefits, that was getting a lot of traction because there's a pretty sizable number of people who meet these vague criteria of cognitive decline and memory loss. It was going to be a potentially massive boost to Medicare spending, which was reflected in Part B premiums, and that only dropped off when CMS decided to cover it only in clinical trials. I think that was a first time that CMS has done that, and they took a lot of flack for it. I think it was the right decision. We don't know what this treatment is doing. We should be studying it in a controlled environment. Physicians were rightfully concerned about prescribing an ineffective drug with known safety risks. And those of us who sit in the policy side, we worry a little bit about what signal we're sending when we lower the evidence bar for new innovators and patents. And I'm going to wrap up with just two examples that I don't have a whole lot to say about, other than their current issues. One is the changes in telehealth policy that were put in place during the public health emergency, which was officially ended yesterday. Those legislative and regulatory flexibilities really made it easier to do the right thing. And most of them were tied to the public health emergency. Some were extended a little bit further. I can't remember exactly. I think as for Medicare, it's 5 months. I think there's something that goes on a little bit longer. But we saw a real success in bringing telehealth into mainstream medical care, and we want to make sure that we don't just go back to where we were, but we evaluate what worked, what didn't work, and enable the positive aspects of it to go forward. And then the other is Medicaid redetermination. So in the beginning of the pandemic, states that chose to waive annual eligibility assessments were given an increase in their federal matching funds. And Medicaid enrollment, because of the Medicaid enrollment surged because people were losing their jobs and their employer-sponsored health insurance, or because they were unable to afford care through the exchanges. And then it leveled off because people weren't being, when they returned to jobs, perhaps they got health insurance on the job, but they weren't being assessed for that. And so now states are having to go forward and redetermine eligibility. It's entirely a state process here. The feds pony up about 50% of the program funding, but the states manage it and are responsible for all the eligibility determinations. And there's a lot of room to go haywire here. Paramount, we want people who got coverage to stay in coverage, and we're particularly for people with chronic conditions and other illnesses, we want to maintain continuity of care to the extent possible. but we're dealing with a whole lot of people. It's around 70 million people. Many of whom are in circumstances that bounce around. They're in employment, they're out of employment. Sometimes they would have access to employer-sponsored health insurance, other times not. Language issues, just basic technical capacity to understand the requirements that are going on. There are challenges for health plans in terms of what they're actually able to communicate to people who might be losing coverage and helping them with whatever their options are. Anyways, this is a big deal. It's going to be unfolding over the next 12 months. Some states will get it right, some will get it wrong, either deliberately or accidentally, and hopefully we can manage reasonably well and learn from the successful states that were successful, and either mimic those processes or at least change horses in midstream to get it right. But if you're tracking insurance coverage and health coverage, you'll be seeing a lot more about redetermination rates. So I've wandered around a number of topics here, and I think, I don't think I will stop here. I will stop here and open things up for questions or observations. Andrew?
Yeah, are there any HAPI students that have any immediate questions? Can either just speak or use the raise the hand function. I could start it off though. I was wondering about for equity and increasing that in non-represented areas. Are there any specific plans that policymakers are utilizing right now or targeting to do that?
Well, policymakers is a pretty broad term because that's federal, state, and local. I mean, I think there have been consistent efforts to talk about the need to do something. I think it has been less obvious what that something should be. I mean, I look back to, say, enactment of the Affordable Care Act, and the focus at the time was reducing the number of uninsured. That's sort of what the statement was. It wasn't about improving health equity. And I think that's, sort of largely a political issue that, when you talk about health equity, part of the audience here is, well, what does that mean? Does that mean I get something out of this, or does that mean somebody else gets something out of it? And so I think we need to both, embrace this as something positive for everyone, that just because somebody else got something didn't leave you behind. It was the fair thing to do. But I don't think very many policymakers have really found a way to message that successfully.
Gay asks, what did the pandemic teach us about care for older people in long-term care?
Let me start with long-term care, and we need to be thinking about much better standards for long-term care facilities. Early on, and in fairness, we didn't know a lot early on, but when you look at the concentration of deaths in long-term care facilities, the inability to get people masked and being able to care for residents as opposed to just isolating residents and then basically locking the doors and keeping them inside. We can learn from that there needs to be a better way to do it. But long-term care facilities are invisible to most of us. We just, unless you've got a parent or a relative in them, it's not something you see every day. It's not something you think about every day. And when you go into them, it's not very easy. I'm sure there are really nice ones, but the ones I've been to over the years are, I don't think I want to end up here, and I certainly don't want to end up here in the midst of a pandemic. Around care for older people more generally, I think we understood very quickly that older adults were at higher risk, and that we needed to be thinking about A, how do we protect them? And B, once we had a vaccine, how do we get that to them and make sure that it's actually safe and effective in them? And these are all, multi-layered strategies. And again, the early days were the punishing days, but once we had learned, when we had rapid antigen tests, so you could make sure that you weren't carrying the virus with you when you were either caring for an older person or going to visit an older person, being, vigilant about masking. I mean, these common sense things. And then when the vaccines became available, get out there and vaccinate people. And, it's instructive. I mean, even in Florida, which has, bragged about its, it's disrespect for the pandemic. They got it pretty quickly that they needed to vaccinate seniors, and the vaccination rates in Florida look very similar to other states that were much more progressive in younger populations, if that makes sense.
Dina had asked how many doctors and healthcare professionals are leaving the medical profession in Arizona. Any idea where these doctors are going?
No, I think a lot are retiring, and I actually might call on Jay Crossan or Sharon Levine if they're still on to weigh in on this, because we've had multiple email conversations about burnout. But if they're leaving Arizona, that's where they used to be flocking to. So if they're leaving Arizona, then I think they're stepping out of their professions.
Yeah, thanks, Murray. I'm going to defer to Sharon on this because we actually had a little bit of a discussion about this with respect to TPMG yesterday. Sharon, are you still there?
I am. I think there are multiple answers to the question, depending on the specialty, and Murray, as Murray referenced, the demographics of the physician population and the nursing population skews older, and there are many clinicians and healthcare personnel who are really harmed during the pandemic, who have decided there must be a better way to live. There's a large, particularly in primary care, an increasing reluctance to commit to full-time practice. And we're seeing, and I think and you'll see this exacerbated, one of the statistics that has definitely gotten worse during the pandemic is maternal mortality. And there is going to be a growing dearth of obstetric and gynecological providers, clinicians available in states that are restricting and significantly restricting reproductive rights. It's already an issue, and this is going to grow worse. And so one of the things I think that the pandemic did was unroof the difficulties that have existed now for a long time between the need and demand for primary care and the growing response of medical students and residents to incentives to choose anything but a primary care specialty. And the burden on the primary care workforce during the pandemic made this abundantly clear. There's a growing interest in locum tenens work compared to committing to a full-time job. There are few primary care clinicians who work full-time are now a minority, as opposed to those who have chosen a 3 or 4 day work week. But the demand continues to grow as the population ages. So it's multifactorial, and money is only part of the solution. One of the quotes incentives that people are responding to is the substantial differential in pay over the course of a career between a primary care physician and an orthopedic surgeon. And when you're graduating from medical school with $250,000 or $300,000 in debt, it becomes very hard to ignore those those numbers and to make an active choice of being a pediatrician versus a plastic surgeon or a dermatologist. So, there are multiple problems to solve. But I would say the most acute issue right now is, if you look across the country, the wait time for a visit for a primary care physician is measured now in weeks, not in days, and that's just not sustainable going forward.
And at the risk of piling on, and this isn't something you solve overnight. There's a long tail, and yes, you can do some things with technology,
Right.
but then, and again, I don't speak as a physician, but for virtual health and telehealth to be successful, it's really helpful to have a relationship to begin with, as opposed to just sort of jumping onto some of these websites that make themselves available, but because they'll prescribe whatever drug that you're looking for. But just we're talking about the seniors in college today who are going to be the primary care physicians a decade from now. That's the pool we're looking at. And the other piece, and it's just anecdotal, but you hear it from a lot of different people on the front lines, physicians and nurses and others. I mean, under the stress of the pandemic and with some social media egging on, the healthcare professionals were being rudely treated and in some cases even threatened, and that's just not a safe environment. And I mean, I can't imagine that coming up in my line of work. It would never be an issue.
Brian, I saw your hand up. Do you have a question?
Yeah, hi. Thanks, Dr. Ross. This is a really great presentation, and really interesting for me because I'm currently working on my capstone for this program, which is about vaccine distribution in the pandemic. And so I'm curious, I know hindsight's 2020, but what are your thoughts on the success of mass vaccination sites, in particular, in the use of the National Guard, sort of big attempt to get lots of people vaccinated? Was that successful? Was that something that you would think we should do again in a future pandemic? How could it have been handled differently?
I haven't looked at it systematically. I think of what happened in California, where there was, Dodger Stadium in Los Angeles was opened up as a mass vax site, and of course, it immediately drew anti-vaxxers protesting the site. I think largely the intention was good, and I think the execution was pretty good. I can speak to my own experience of getting vaccinated at the community college a mile from my house. And granted, we're blessed with good weather in California, so we could stand in line outside the building. But you weren't standing in line; you were moving in line the whole way through, and they were very, very fast. And when I went for a booster shot with Kaiser Permanente, are you team Moderna or are you team Pfizer? You get an orange card or a green card. You follow the orange line or the green line, and it was really easy to do and really fast. You weren't exposed in a system for a long time. I think mass vaccination works when there's an immediate threat, when people were clamoring for the vaccine. And then we've also seen, later on with the boosters, there's less enthusiasm for it. You need that bolus of people to justify using a mass vaccination site. I think they were generally successful, but that was a very short period of time. That was spring of 2021, and after that it's been much more localized, and again really encouraging the people who are at risk to make sure they're vaccinated. Does that get to your question?
Yeah, that's great. Thank you.
Ella had asked if you would mind speaking more on the specialty care access that you mentioned during the presentation, specifically in relation to the topic of burnout.
I think
That was sort of it. I guess I meant more generally, or as we were discussing burnout, where you kind of have people going into specialty care in terms of reimbursement rates and not being in the primary care side of things, and then kind of the model of KP of increasing access. But go ahead. I'd like to hear your thoughts.
Well, for the most part, when I think about burnout, I'm not thinking about specialty care. And again, Sharon spoke to this eloquently. It's the people in primary care dealing with a sort of a broader population, a constellation of illnesses and circumstances. The specialists I'm in closest contact with are orthopedic surgeons, and they don't seem burned out at all.
I'm sorry. I guess I meant the conflict between the two. You have one really burnout group and another not, and how those two interact and whether that increases burnout and some of the barriers of referrals and everything like that.
I don't know that it has that kind of interaction, and again, I'll defer to Dr. Levine, but we talked about this with our students at the medical school, that there's been a loss of prestige. And it's one thing to say, my job is a little bit tougher and everything else, but it's also, I'm not awarded the respect I deserve for what I'm doing for people the way it was in the past. And I don't know that causes friction between primary care physicians and specialist physicians. I think it just causes lower satisfaction levels with primary care docs. Sharon?
Yeah, I'll add to that just a little bit. I think one of the things that happens when primary care is under stress is there's a tendency or an instinct to say, what of this care can I offload by sending a rash I could have managed myself to a dermatologist, or low back pain that isn't an orthopedic surgical problem, but I don't have time to deal with the issue of chronic pain in the context of low back pain. So I'll send a referral to the orthopedist. And if there is any tension, this is outside the pandemic, between primary care and specialty care, it's specialists thinking, why aren't you managing this yourself? And primary care physicians saying, this is in your lane. Why don't you take this on and manage it?
Yeah, to be clear, Sharon, you're speaking with your Permanente hat on there, because in the outside world, the specialists are saying, thank you for the referral.
Yes and no, not always, but it became a particularly acute during the pandemic. And I think one of the challenges now for primary care is bandwidth, and whether or not and what is it appropriate for a head and neck surgeon, an ENT surgeon, to be seeing children who have chronic ear infections because the primary care practice is overloaded. As Murray said, they're probably happy to do it because they get to bill at their surgical subspecialty rate. But from a system perspective, the cost of underinvestment in primary care is enormous in many ways. One of which is it leads to a lot of unnecessary care that could have been managed early on and prophylactically in the office of a good primary care clinician. And it's creating backlogs for, there are enormous backlogs now for some specialists. Neurologists in the community have a 3-month wait list because they're being asked to manage people with minor headache, chronic headaches, things like that. So there, maybe from a revenue perspective, the neurologist practice is happy to have a long wait list. But from a systems perspective, in terms of how do we right size the physician workforce, and ensure that people are able to get the care they need when they need it in the most appropriate setting, and early enough to prevent acute problems from becoming chronic problems.
Awesome. Annette, I saw your hand up. Do you have a question?
Yes, hello. Thank you for an excellent talk. I just, being in Sweden at Karolinska Institute, I was curious about what were the main channels for people to get to be educated when the virus started. Where were they heading to get to? There was a lot of people to learn about how to behave in public spaces. I know for sure that in Sweden we had top vaccine researchers and the Director General of the Public Health Agency of Sweden. They were on television every morning, every evening, every week for like months. So they must have been just really tired just by like being there, answering questions. So I wonder how was it in the United States? What were people? How did they get how did they inform themselves about how to protect themselves?
It was very different. On the one hand, you did have people like Dr. Fauci, an infectious disease physician from the National Institutes of Health. He was on television almost every day. And as the science changed, sometimes what he was telling people was changed, and he took a lot of criticism for that. And the response is, well, we go where the science goes. Those of us who believe in science are comfortable with that, and people who are skeptical say, but you just changed your mind. How do I know which one's right anymore? And then you compound that with people who are sort of actively trying to exploit that for whatever purpose they have. I don't know that it is, whether it's anti-vaxxers or just people who like to disrupt things. I don't know how much more prevalent that is in the United States, but I think it's more prevalent. And they're going on to their own, social media channels online, and people get into their own, they acquire a lot of their information or their news, if you will, from their own camp and their own echo chamber. And that's a real challenge. I mean, in an event of this size, of its magnitude and severity, you're going to expect some stumbles. This was brand new. And when you have people actively, for political persons saying, oh, it'll go away in a few weeks, don't listen to my science advisor who's telling you that you should be masking up and isolating and all of those other things. So a lot of mixed messages out there, that if you were even just a neutral person, you're getting conflicting messages. And if you were going into, and I think it's obvious which camp I'm in the science and evidence camp. If you were going into the opposite camp, you could find things to reinforce and reflect your views back to you. And it's and it's ongoing. I mean, it's the amount of misapplied statistical analysis to show that the pandemic, that COVID-19 was no worse than the flu, to exaggerate the risks of mRNA vaccines in young men, but then never compare those risks with the risks of actually getting COVID. It goes on and on. It's persisting. I mean, I see this in my feeds every day, that these conversations are ongoing, and they're not resolving. Truth didn't win. And we're also relitigating the public health measures and having contests among governors about who did the best job, because they reopened early, because and the evidence is pretty mixed there, actually. and some of it reflects, underlying, population characteristics and density, and who got hit earliest. I mean, New York City looks pretty bad because it was the first epicenter of the epidemic. And it's just not fair to compare New York City's experience with Dallas, Texas. They were different places at different times. But that's a nuance that gets lost on people who aren't particularly interested in explaining things.
Murray, I just make one comment, because what I've been seeing recently, even among my circle of friends and beyond that, of course, is kind of a collective amnesia regarding the pandemic. I've talked to friends who are, as you say, scientifically based about things like, well, there's still a reason that you might want to wear masks inside and not eat inside in a restaurant, but nobody wants to hear that anymore. Does anybody remember that we had 1 million Americans die during this? Well, yeah, but they were somebody else, and it strikes me because, as I reflect back on, for example, my parents' life, having gone through the Depression and the Second World War, the memories and the lessons from that persisted well into my life. And yet this particular trauma seems to have evoked a different response, even among thoughtful people.
Yeah. There was something in the New York Times this morning from late night TV last night about, again, President Biden declaring the public health emergency over and sort of, jokingly saying, well, the rest of us knew that a year ago. I have been wondering a little bit, and this is utterly speculative, but given the number of people who seem to have had trouble imprinting memories during the pandemic, simply because they didn't have variability in their routine, they didn't get the change that allows you to imprint, how much that actually sort of aided and abetted that loss of memory that you described, Jay. So it's not organic memory loss, but just situational memory loss.
Not seeing any hands up right now. I have my own question, so I'll exercise my instructor's prerogative here. So one of the lessons I think that you mentioned of COVID is something I thought a lot about, and that is kind of the role of technology and telemedicine and better ways to do things in some cases that we learned because we had to do them. But I'm also impressed by the fact that when you introduce something like technology to the equation, what you're really doing, in addition to the good stuff, is you're amplifying some of the healthcare disparities that exist around access to broadband, access to internet at all, access to good insurance, whatever they are, they get amplified when you have to do it through technology. And I also, as a member of Kaiser for many, many years or decades, Kaiser's kind of was at the forefront of these kind of things, and they were ongoing even to some extent before the pandemic, and they were in a good position to adopt them. And you could see the strains on the Kaiser system as a consumer, and still do, but they handle it better than I thought they might. But I'm wondering internally at healthcare organizations, HMOs, et cetera, is there much thinking or plans to do anything about the fact that when you go into telemedicine, when you start using secure mail systems, et cetera, that what you're really doing is accentuating in part some of that inequity that exists to begin with socioeconomically regarding technology?
Yeah, no, this is something that we've actually been thinking about for at least 15 years, just within our own population. So we're not going to not adopt the technology for fear that we're leaving the rest of the world behind, but we're very cognitive of it. And at least simple metrics that we've looked at. So use of virtual care to telehealth visits. This is pre-pandemic now. there were concerns just, would older people who might be either less tech savvy or just less tech enabled, turns out their use rates are, and got to control for health status here, but their use rates are well above younger populations. Because the technology may be challenging, but the absence of technology was a challenge. If you can't drive anymore, you don't have good access to public transit, you weren't going to the doctor at all. Now maybe there's a way to do it. I think we have also done pilot programs with basically putting technology into people's hands, because it doesn't actually cost that much to give people access there. I would also note that we have also been very active in this space through my now former Institute for Health Policy. We've done several events on digital health equity and basically saying, we're well aware of these, and here's what we're trying to do about it to encourage sort of the rest of the world to catch up on it.
Okay, great. Do you see any other questions out there, Andrew?
I don't see any.
Okay, I put in the chat the next week's speaker, who is Peter Swenson, who a lot of you I think know from Yale, who's going to be speaking about organized medicine's alliance with the pharmaceutical industry. So I hope some of you will return. I want to really thank Murray for taking on the speaking assignment at a time that's disruptive and I think in some ways disoriented when one retires. And I'm sure you'll take the same path that I did recently, which is to keep your feet in it in some way. And we'll look forward to hearing and seeing more of what you're doing. So thank you so much. And I hope to see most of you back next week.
Well, thank you for having me.
Thanks so much,
Yeah.
Murray.
I know.